So again to all, may God's guidance and protection be upon us all as we continue in our life journey. Alright, so again, this is the part 2 of our presentation on gastrointestinal system. So again, before moving on with this presentation, let me again present to you these disclaimer slides. So again, this is the part 2 of the physical examination of the gastrointestinal systems. And again, these are the learning objectives. Now, let's proceed with the physical examination of the liver. So the rib cage shelters most of the liver and can make assessment very difficult. So we cannot palpate the liver, no? Just the margins and the edges of the liver ang possible na pwede nating ipalpate. However, kailangan pa rin talaga ng more practice. Okay. So the liver size and the shape can be estimated by percussion and palpation. So liver consistency and tenderness is or can be examined by palpation, of course, by an expert, no? So as a student, so maybe difficult at first, so you need to practice it. Okay, you can measure the vertical span of the liver or the liver dullness in the right mid-clavicular line. Okay, from here, no? And then how to do it? Of course, first you have to locate the mid-clavicular line carefully. That is for you to improve accurate measurement. You can use a light to a moderate percussion stroke because, of course, remember that a heavier stroke can underestimate the liver size. So you can start at the level below the umbilicus, okay, in an area of tympany or not dullness. So you can percuss upward toward the liver. Okay, identify the lower border of the liver or the lower border of dullness in the mid-clavicular line. Okay, so next, you can identify the upper border of the liver dullness in the mid-clavicular line, starting in the nipple or the nipple line. Percuss naman downward in the mid-clavicular line until the lung resonance shifts to a liver dullness. For women, you can gently displace the breast as necessary for you to be sure to start in a resonant area. So, ito yung dullness kasi. So, sa taas yan, resonant yan kapag pinarkas mo. Because nandyan yung lungs. Okay? The course of percussion is shown in this picture. So, you can start from here. Ayan. Okay, yan mga squares din dyan. Dyan ka maglagay ng iyong finger. Then, dyan ka start ng percussion. Tapos, dito naman sa taas. No? Now, you can measure in centimeters the distance between the 2 points. Yan, the distance between the 2 points. Okay, the vertical span of the liver dullness. It's okay. The normal liver span is shown in this image. That is generally greater in men than in women, and greater, malaki din siya in taller compared to shorter people. So if the liver seems to be enlarged, you have to outline the lower edge by percussing medially and laterally. So lateral, medial. Remember that in chronic liver disease, finding an enlarged palpable liver or palpable liver edge roughly doubles the likelihood of there could be liver cirrhosis. Okay, so now let's proceed to palpation. So after doing the percussion of the liver, now let's proceed with the palpation. How to do this is you have to place your left hand, okay, behind the patient, parallel to and supporting the right 11th and the 12th ribs, and adjacent soft tissues below. So you have to remind the patient to relax on your hand if necessary. So by pressing the left hand forward, the patient liver may be felt more easily by your examining hand. So you have to place your right hand on the patient's right abdomen, lateral to the rectus muscle, with your fingertips well below the lower border of the liver or the liver dullness, no, upon percussion kanina. So, some examiners point their finger up toward the patient's head. So, naka-up, no? Whereas others prefer a somewhat more oblique position like you can see in this picture. So, you can ask the patient to take a deep breath and try to feel the liver edge as you slide down to meet your fingertips. When it is palpable, the normal liver edge is usually soft, sharp, and regular with a smooth surface. If you can feel the edge slightly lighten the pressure of the palpating hands so that the liver can slip under the finger pads and you can feel its anterior surface. Please take note if there is any tenderness. Okay, the normal liver may be slightly tender pag na-touch nyo siya. So if you ask your client to breathe during inspiration, so the liver is palpable about 3 cm below the right costal margin in the mid-clavicular line. Okay, so this image shows a liver enlargement. So we have here a downward displacement of the liver by a low diaphragm. This finding is common when the diaphragm is flattened and low, usually in those patients who are diagnosed with COPD or chronic obstructive pulmonary disease. So, the liver edge may be palpable well below the costal margin. So, percussion, however, reveals a low upper edge also. And the vertical span of the liver is normal. So here, this is an image of normal variations in liver shape. So in some individuals, the right lobe of the liver may be elongated and could be easily palpable as it projects downward toward the iliac crest. So, to continue with the liver enlargement, we have here a smooth, large liver. So, this is due to or produced by cirrhosis with a firm, non-tender edge. So, the cirrhotic liver may also be scarred and contracted. And we have here irregular large liver. So, it is actually firm or hard with irregular edge or surface that could suggest a hepatocellular carcinoma. There may be one or more nodules, so the liver may or may not be tender. Okay, so now let's proceed to the spleen. So when the spleen enlarges, it expands anteriorly, inferiorly or downward, and medially. So it often replacing the tympani of the stomach and the colon with the dullness of a solid organ. So then it becomes palpable just below the costal margins. So there are two techniques that helps us detect splenomegaly or enlargement of the spleen. First, we can do percussion, or you can percuss the left lower anterior chest wall from the border of the cardiac dullness at the sixth rib to the anterior axillary line and down the costal margin. Okay, so you have to check for dullness. So as you percuss along the routes shown in this arrow, okay, you have to note the lateral extent of the tympani. So if percussion dullness is present, palpation correctly detects splenomegaly. So more than 80% of the time daw. So you have to check for a splenic percussion sign. You have to percuss the lowest interspace in the left anterior axillary line as shown in this picture. Then you have to remember that this area is usually tympanic. Then you can ask the patient to take a deep breath and then percuss again. When the spleen size is normal, the percussion note usually remains tympanic. So, hindi siya dull kapag normal yung size ng spleen. Okay? And then, after doing the percussion, you can proceed with the palpation. Again, remember that there are only two techniques to assess splenomegaly, and those are the percussion and palpation. So, to enhance relaxation of the abdominal wall, the patient should be keep on supine position with the arms at the sides and flex the neck and legs for comfort as necessary. With your left hand, reach over around the patient to support and press forward the lower rib or the lower rib cage and adjacent soft tissue. So your right hand, you have to place it below the left costal margin, and then you can press it toward the spleen. So you can now begin palpation low enough so you can detect an enlarged spleen. So again, this is you need to have more practice to be able to determine kung spleen nga talaga. So if your hand is too close to the costal margin, you will not be able to reach under the rib cage. So ask the patient to take a deep breath and then try to feel the tip of the edge of the spleen. So as your hands comes down to meet your fingertips, note if there is any tenderness and then assess the splenic contour, and you have to measure the distance between the spleen's lowest point and the left costal margin. Okay. Splenomegaly or enlargement of the spleen is 8 times more likely when the patient or when the spleen is palpable. So, ibig sabihin, kung napalpate mo yan, ibig sabihin there is an enlargement. The causes could include the following, no? Portal hypertension, or there is hematologic malignancies, etc. So repeat with the patient lying on the right side with the legs somewhat flexed at the hips and knees. Because in this position, gravity may bring the spleen forward and to the right into a palpable location. So the enlarged spleen is palpable about 2 cm below the left costal margin on deep inspiration. So let us now proceed to the kidneys. Okay. So again, the kidneys are retroperitoneal. So ibig sabihin posterior organ siya. And usually not palpable, but learning the techniques for examination could help you distinguish enlarged kidneys from other organs and abdominal masses. So after doing the palpation, now it's the time for you to do the percussion. So percussion tenderness could be done over the costovertebral angle. Okay, so you can assess during examination of the back. So the pressure from your fingertips may be enough to elicit tenderness. So if not, you can use fist percussion. By placing the ball of your one hand on the costovertebral angle and then strike it with the ulnar surface of your fist. Use enough force to cause a perceptible but painless jar or thud to save the patient need. Okay, so the pain with pressure or fist percussion could suggest pyelonephritis, which is usually associated with fever and dysuria, but may be also due to musculoskeletal. Now let's proceed to the bladder. So the bladder normally cannot be examined unless distended or above the symphysis pubis. So you have to check for tenderness and you can percuss for the dullness. Okay. So moving on to the aorta. Okay. Press firmly or deep in the upper abdomen, slightly to the left of the midline, and then identify the aortic pulsation. So ito yung sinasabi ko kanina in the previous slides. In people older than age 50, you can assess the width of the aorta by pressing deeply in the upper abdomen with your one hand on each side of the aorta. So as you can see in this picture. So a normal aorta is not more than 3.0 cm wide. So the average is 2.5. Okay, so let's have a break, by giving you these questions or review. Okay, the abdomen can be examined entirely from one position. Is it true or false? I'll give you 5 seconds. All right. Okay, so this is the answer of the question. So the abdomen can be examined entirely from one position. Of course, it is false because costovertebral angle tenderness is evaluated by percussion on the back. So to assess for ascites, it is best to have the patient roll to their side. So hindi lang siya nakasupine. Even for the kidneys, di ba? So these are the special techniques, that you will do when you are assessing for ascites, appendicitis, acute cholecystitis, ventral hernia, and mass in the abdominal wall. So these special techniques will be discussed in the next slide. Alright, so to continue with our special techniques in assessing possible ascites, okay, protuberant abdomen with a bulging flanks is actually suspicious for ascites. Ascites is the common complication of liver cirrhosis. So it is because the ascitic fluid characteristically sinks with gravity, whereas the gas-filled loops of bowel rise. So dullness appears in the dependent areas of the abdomen. So you have to percuss for dullness outward in several directions from the central area of tympani, as you can see in this picture. So map the border between tympani and dullness. So ascites can be a clue to increased hydrostatic pressure in cirrhosis, which is most common. So, pwede rin magkaroon ng heart failure, constrictive pericarditis, or inferior vena cava, or hepatic vein obstruction. Okay, so there are two additional techniques to help confirm ascites. Although both signs may be misleading. So you have to test for shifting of dullness. Ayan, shifting of dullness. Percuss the border of tympani and dullness with the patient on supine position, and then you can ask the patient to roll to one side. Percuss and then mark the borders again. In a person without ascites, the borders between tympani and dullness usually stay relatively constant. Okay. Let's continue with the second. Okay, another technique, no? Or, di ba, ito yung two additional techniques. So, ito yung pang number 2, yung test of fluid wave. Okay, so you can ask the patient or an assistant to press the edge of both hands firmly down the midline of the abdomen. This pressure helps to stop the transmission of a wave through fat. While you tap one flank sharply with your fingertips, feel on the opposite flank for an impulse transmitted through the fluid as shown in this picture. Unfortunately, this sign is often negative until ascites is obvious and is sometimes positive in people without ascites. So not that accurate. So in ascites, dullness shifts to the more dependent side, whereas tympani shifts to the top. Okay, so let's continue with assessing for possible appendicitis. Okay, so you can ask your client, where did the pain begin? So the location, no? Where it is now, does it radiate? Area of local tenderness, is there muscular rigidity? And you can do pelvic or rectal examination for women. So please take note that appendicitis is a common cause of acute abdominal pain. So you have to assess carefully for the peritoneal signs of acute abdomen and the additional signs of McBurney point tenderness, or the Robson sign, SOA sign, obturator sign, okay, and cutaneous hypertension. So, remember that the pain of appendicitis classically begins near the umbilicus or peri-umbilical. Then it migrates to the right lower quadrant. However, for the older adults, these are likely less to report this pattern. So you can ask the client to point to where the pain began and where it is now. Okay. Ask the patient to cough and determine where the pain occurs. So then you can ask the patient to point to where the pain began and where it is now. And then ask the patient to cough and determine where the pain occurs. Now you can palpate carefully for an area of local tenderness. So the McBurney point lies 2 inches from the anterior superior spinous process of the ilium on a line drawn from the process to the umbilicus. So, localized tenderness anywhere in the right lower quadrant, even in the right flank, could suggest appendicitis. Okay, so you can palpate for Robson sign and for referred sign or referred rebound sign by pressing deeply and evenly in the left lower quadrant and then quickly withdraw your fingers. So kapag masakit yon or there is pain in the right lower quadrant during your left-sided pressure, it is a positive Robson sign. So how will you assess for SOA sign? By placing your hand just above the patient's right knee and then ask the patient to raise the thigh against your hand. Alternatively, you can ask the patient to turn onto the left side, then extend the patient's right legs at the hip, flexion of the leg at the hip makes the psoas muscle contract, or extension stretches it. So, if there is increased abdominal pain on either maneuver, it is a positive psoas sign, that suggests there is an irritation of the psoas muscle by an inflamed appendix. So, how will you assess for obturator sign naman? This sign has very low sensitivity. How will you do this? Flex the patient's right thigh at the hip with the knee bent and rotate the leg internally at the hip. This maneuvers stretches the internal obturator muscle. So may pain din na mararamdaman si patient. So the right hypogastric pain is a positive obturator sign, suggesting irritation of the obturator muscle by inflamed appendix. Okay, so let us now proceed to assessing possible acute cholecystitis or inflammation of the gallbladder. So, you have to assess if there is a right upper quadrant pain, or if the pain is located at the right upper quadrant, and then assess for Murphy's sign. So to do this, or to assess for Murphy's sign, you can hook your left thumb or the fingers of your right hand under the costal margin at the point where the lateral border of the rectus muscle intersects with the costal margin. And then alternatively, you can palpate the right upper quadrant with the fingers of your right hand near the costal margin. So if the liver is enlarged, you can hook your thumb or fingers under the liver edge at a comparable point below. And then you can ask the patient to take a deep breath, okay, which forces the liver and the gallbladder down toward the examining fingers. And then you have to watch the patient's breathing. And you have to take note for the degree of tenderness. Gaano ba ka-painful? Can you use your pain scale? Moving on to assessing ventral hernias. So ventral hernias are hernias in the abdominal wall exclusive of groin hernias. So if you suspect but do not see an umbilical or incisional hernia, you can ask the patient to raise both head and shoulders off the table. So the bulge of a hernia will usually appear with this action, but should not be confused with diastasis recti, which is benign. 2 to 3 cm gap lang in the rectus muscles that are often seen in the obese and postpartum patient. So let's have a question again, no? So the right lower quadrant pain in females can be an indication of which of the following? Okay, so you have to choose all that apply. All right. The correct answer are the following. So the right lower quadrant pain in females can be an indication of which of the following. Choose all that apply. Okay, so all of these conditions may present with right lower quadrant pain in female. Kasi all of these organs are located or can be found also in the right lower quadrant. Now let's proceed in recording your findings, which is an important part of your nursing care plan or in your nursing care. Of course, you have to record the following for the abdomen, include the contour, tenderness, palpation, percussion, vowel sounds, and abnormal structures. Okay, so moving on. So, to help promotion, of course, after gathering all the data, after identifying the possible problems or the current problems of your client, it's now time for you to do your health teaching or to create your program for health promotion. So the health promotion topics includes the following: no screening for alcohol abuse, okay, risk factors for hepatitis A, B, and C, and screening for colon cancer, and prevention of urinary incontinence. So those are the topics, or this should be the focus of your health teaching. Okay, for screening for alcohol abuse, these are the classic findings. Okay, kapag mahilig talagang uminom si patient, no? There could be a possibility of hepatosplenomegaly or enlargement of the liver in the spleen, or there is an ascites as a result of liver cirrhosis, or there is a caput medusa. Okay, spider angiomas, this was explained in our integumentary system, no? Jaundice and palmar erythema. Alright, so to screen for problem in drinking or alcoholism, you can refer in this table. Okay, so there is comparison between men and women here kung ilang drink a day. So you can use this table. Okay, so to continue with our health promotion, you can include the following risk factors for hepatitis A virus or your HAV. So, hepatitis A virus can be transmitted via oral or via fecal oral. Okay, children who are affected by the virus often asymptomatic. So, there are vaccines that are available. For those who are exposed to this virus, there is what we call a post-exposure prophylaxis, the serum globulin. Okay, stress good hand washing techniques. Okay, before and after eating, before and after going to the comfort room. Okay, so these are the CDC recommendations for hepatitis A vaccination. All children at age 1 year should be vaccinated. Individuals with chronic liver disease, the groups that are increased risk of acquiring HAV, especially those who travel or live in a high endemic rates, homosexual activity, injection or illicit drug user, or working in HAV research, or those who have clotting factors disorders, and especially those who are also receiving blood products. Okay. Now let's proceed to the risk factors for hepatitis B virus or the HBV, which is actually a more serious threat to health. Most asymptomatic until develop symptoms of advanced liver disease na. There is 3 risk categories. Okay. Sexual contacts. Dito natatransmit, no? Kasi via blood or mucus. Pwedeng ma-transmit yung hepatitis B virus, or with the people with percutaneous or mucosal exposure to blood, and others, those who are travelers, patients with chronic liver disease or HIV infection, people seeking protection for hepatitis B. Those are categories. Okay, so let us now proceed to the risk factors for hepatitis C virus. Okay, so these are common to those who have repeated percutaneous exposure to blood, illicit IV drug users, those who undergo a transfusion with clotting factors before 1987, those who are undergoing hemodialysis, and those who have sex partners using IV drugs, and those who have blood transfusion or organ transplant before 1992, and those who have occupational exposure, lalo na yung mga healthcare workers. Okay, those who have multiple or infected sex partners. Okay. So moving on to screening for colorectal cancer. So it's important to assess the risk factors for the past colorectal cancer or adenomatous polyp. Okay, history of inflammatory bowel disease, family history of colorectal cancer or adenomatous polyp. Okay, so to continue with the screening for colorectal cancer, so prevention, no? It's important to screen for and remove precancerous adenomatous polyps. And then, of course, fecal blood testing or flexible sigmoidoscopy. And physical activity, dapat improve yung physical activity, no? Hindi lang sedentary, and use of aspirin, NSAIDs, and HRT. So the US PSDF recommends against NSAIDs and aspirin due to risk outweighing the benefits in average risk individuals. So these are the screening tests for colorectal cancer. We have the occult fecal blood. Okay, usually for fecal immunochemical test or high sensitivity GIAC-based test. So this is also to test for abnormal DNA. So endoscopic test, or we have colonoscopy and flexible sigmoidoscopy. So another screening test for colorectal cancer are imaging studies, wherein this includes double contrast barium enema and CT colonography. So any abnormal findings should be followed up with a colonoscopy, which has potential complications and risks as well. So screening recommendations for colorectal cancer are those adults ages 50 to 75. So high sensitivity fecal occult blood testing annually, either a GIAC-based or fecal immunochemical test. So, and sigmoidoscopy every 5 years with high sensitivity FOBT every 3 years, and screening colonoscopy every 10 years. So this is just a continuation. So adult ages 76 to 85, individual decision based on the overall health in the prior screening. So no. So if the patient is healthy and can withstand treatment if cancer is detected, or do not have comorbid conditions that would limit life expectancy, or if never screened, more likely to benefit. So now let's move on to urinary incontinence, which is an involuntary action. So women experience more than men. So men usually after prostate surgery experiences urinary incontinence. So many patients believe it is normal when aging, and it is reversible. So we have bladder incontinence severity index. So you can use this one to check, no, kung ano ba talaga yung problem sa kanyang bladder. How often do you experience urine leakage? 0 kapag never, 1 less than once a month, 2 1 or several times a month, 3 1 or several times a week, and 4 every day or every night. Okay, so, and then to continue with your bladder incontinence severity index, you can ask how much urine do you lose each time? So 1 drops or little lang, 2 more. So also check for total score by multiplying question 1 by question 2. And then you can refer it here, yung result. 0 as dry, 1 to 2 slight incontinence, 3 to 5 na score moderate incontinence, for 6 to 8 that could mean severe incontinence. So the following are the identification and education key to assisting patients. So you can teach your patient to do pelvic muscle exercises, behavioral changes, okay, to relax kasi baka na-stress lang, use of pessary and biofeedback. So that ends our presentation on our first topic about the physical examination of the gastrointestinal system. So let me again end this presentation by sharing to you this quote by Luke chapter 1 verse 37. For with God nothing shall be impossible. So let's keep fighting. Thank you everyone and God bless.